Veterinary Surgeon, Dr. Shammas. Over to you.
Thank you all and welcome. So today's topic is mainly about knee joint, but this is applicable to any joint in the body. So we'll start. So when you think of a degeneration of the knee joint, we always think of replacement as the final solution. And that is true in every sense. Because total knee arthroplasty is one of the most cost-effective and consistently successful surgery in orthopedics for all end-stage degenerative osteoarthritis and inflammatory arthritis. You don't have any other option. So what does it do? It alleviates the pain, restores function, and leads to an improved quality of life. And again, in inflammatory arthritis, like rheumatoid arthritis, if you look into that, you'll see that it has proven to be a highly successful treatment for advanced rheumatoid arthritis. And more than 80% of patients with RA will have a satisfactory result for 12 to 15 years. So that is the case of inflammatory arthritis. So what is the age when you want to do a total knee replacement? If you want to do a total knee replacement at 70 years of age, it is well and good. It is a very good option. But before that, if your knee burns out, if your knee is in a very bad condition, what can you do? At 40 years of age, at 50 years of age, at 60 years of age, if your knee is going into a very bad condition, what can you do? You should not, or you should not go into a knee replacement, because what happens is, so this is what I said, for end-stage arthritis, either it is inflammatory, traumatic, osteoarthritis, anything, the total knee replacement has a proven track record. It is total knee replacement. It is a final word. There is no discussion about it. So if the bone joint is like bone on bone and it is severe arthritis, then it is total knee replacement. You don't have any other option for that. So in this X-ray you can see that in the left knee you don't have a joint space. In the right knee you have a little bit of joint space. Okay. So in this case there is no other option other than doing a total knee replacement. So this case we did 2 days back, and the patient is still admitted here in our hospital. And this is what we did. I did only for the left side. I did not do it for the right side. So this is a total knee replacement. So is a total knee replacement the panacea of all knee joint problems? So that is what we have to discuss. So after a total knee replacement, what you will have is, you will have normal activities with limitation. So what you will have a restriction in range of movements. You cannot sit down. You cannot sit cross-legged. You cannot squat. And you cannot do high impact activities after total knee replacement. All these are facts. And you should constantly watch out for infections. And the chance for a resurgery due to the plastic wear is very high after 10 to 15 years. And again, periprosthetic fractures. That is also a well-known complications, because juxta means close to the implant, you will have osteopenia. And when osteopenia occurs, a trivial trauma can result in a fracture. So it is a periprosthetic fracture. And a periprosthetic fracture is very difficult to be dealt with because you have an implant, and you should not displace that implant, and you should be very careful in putting a plate or a nail in that. So it is a very difficult situation. A periprosthetic fracture is a very difficult situation for a surgeon. And again, the most dangerous of the complications, what is that? Is infection. If you have an infection, there is risk of multiple surgeries. Once the total knee gets infected, you will go in for 1 surgery, 2 surgery, 3 surgery, maybe 4 surgery. And all these surgeries means a lot of money is involved. It is very expensive. And the general condition of the patient will deteriorate in the coming years. And sometimes you may end up with a non-functional or a stiff knee joint. And in an extreme case, you can even end up with amputation of the limb. So all orthopedic surgeons will go through all this in their lifetime. So in a younger patient, do we have something? That is what we have to discuss today. If you do a TKR in a 45-year-old patient, anyway, the TKR will go on for, you can say, 15 years, 15 to 20 years, you can say. 45 years, when by 65 years, again another surgery. So there is a revision. So everything will be like that. Joint preservation, the principle is prevention is better than cure, and the native joint is better than an artificial joint. So preserve and prevent injuries to the native joint. That is the most important thing. So the human knee, you see, we know, we have studied in anatomy, we have the femur, we have the tibia, the patella. In the eyes of an arthroscopic surgeons, we see some ligaments, we see the cartilage, we see the bone, 𝗥𝗲𝗽𝗋 means the subchondral bone we see. And an arthroscopic surgeon views a joint as an organ in which there are multiple structures, all synchronously acting to produce a perfect function of the joint. So ligaments, if you have a ligament injury, you are, say, 20 years of age, or you are 50 years of age, up to 20 to 50 years of age, you have a ligament injury, you should treat it. You want to preserve your joint, you should treat the ligament injury. There is no other option. Because sometimes we'll feel sad for those boys and girls who come to us after having a ligament injury, say an ACL injury. And they'll be very passionate with their sports. They'll keep on playing. They will have dislocations. They will again play. They will fall down, again play. After 5 years, what happens is the joint, the meniscus will be completely worn out. It will be torn completely. And the cartilage, that again will be completely destroyed. We have seen patients 27 years, 26 years, when you put the scope inside, the knee joint will look like a patient who is 70 years of age. That much did not treat it. And what happened? The whole knee is destroyed. So, first thing is ligament injury. So, what are the ligaments inside the joint? Nowadays, even layman knows that we have an ACL ligament, we have meniscus. People will come and say, "Doctor, I am having an ACL tear," like this. So the ligaments inside the joint, usually it comes as ACL, the PCL, posterior cruciate ligament, and meniscal injuries. Sometimes you'll see meniscal cyst or parameniscal cyst. Small swelling in the medial side or the lateral side close to the joint. These cysts are actually, this arises from the meniscus. A meniscus will be torn and the joint fluid will not allow that meniscus to heal. So it will create a cyst over there and the patient will complain of a swelling near the joint. So if you have a meniscal injury, this is what we do. In a case of a meniscal injury, this you are seeing the medial meniscus, and I am putting my probe into the gap in the tear of the meniscus. This is the capsular side, and this is the articular side. This instrument is called a rasp. We put the rasp inside, and then we rub it against the torn parts of the meniscus, so as to make it into bleeding ends, and then we try to suture it. We suture it intra-articular arthroscopically. We put multiple sutures. It is like 12 sutures, 18 sutures, like that. Minimum 8 to 12 sutures you will have to put. These are the sutures coming in. So this is what we do in the case of a meniscal tear. So these are multiple sutures that is being put. This is all done arthroscopically. You don't have to open the knee joint. So you can see the multiple stitches that are coming. So multiple stitches. Then this is a fibrin cloth that I am keeping in between the tear. This is, meniscus is in the inner side it is avascular. So there is high chance that it can go in for a non-union. So we put some biological agents in between. So this is a fibrin clot. We actually make this fibrin clot from the blood of the patient itself. We take the blood of the patient, we centrifuge it, we make it into fibrin clot, and then we put it inside the meniscus, in between the tear. So that is about the meniscal tears. So these are the wires that are passed. That is called the endo button. That button will fix on the femoral side. Now the graft has come inside. That purple mark is a graft. Is on the graft. See, this is a shiny and beautiful graft that we have reconstructed. This is actually a hamstring graft. So that is with ACL. So if you have a meniscal injury or an ACL injury or a PCL injury or a PLC injury, you don't have any other option. You should treat it. Otherwise, you lose your joint. So that is the first thing that we have to do. So that is the meniscal ligament part. The next part is the cartilage. So cartilage again can have injuries. What is the cartilage inside the knee joint? It is hyaline cartilage. You have other cartilage like elastic cartilage, fibrocartilage. But inside the knee joints, it is the hyaline cartilage. And till date, we are not able to recreate something like the hyaline cartilage because it has the smoothest of the surfaces and it has the ability to withstand high pressure. And till date, we have not created anything like that, like the cartilage. The problem is, it is alymphatic, aneural, and avascular. So there is no option for healing. So that is our cartilage. So we have only a 3 millimeters thickness of the cartilage, only 3 millimeters thickness, usually, almost in all our joints. In the talus and all you have, but only 3 millimeters. But this 3 millimeters of cartilage is so tough that it will take 70 years for that to wear and tear. For that to get destroyed, it gets that 3 millimeters. It will take 70 years. So how strong it is. But if that is lost, then we don't have options. So what options we have? So this is a pictorial representation. You can have a chondral defect, that is a cartilage defect. It can be a partial thickness, it can be a full thickness, or it can be a osteochondral. That means a part of the subchondral bone also is lost. So operative techniques for articular cartilage injury includes chondroplasty, marrow stimulations like microfracture, 𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 arthroplasty, autologous chondrocyte implantation, autocart procedures. So all these procedures, and even now we are trying to develop newer techniques to regenerate our cartilage, to reproduce our cartilage and make the cartilage normal. So osteochondral autograft transfer. So in this case, what we do is, this is definitely a joint preservation surgery. Definitely a joint preservation. You can preserve the joint by this. So the main thing is we'll have to take an MRI, and if you carefully look at the MRI, you can see that the cartilage is visible here, but when you reach here, the cartilage is not seen. And you find some piece lying in the intercondylar area. Again, in the sag view also, you can see that there is a cartilage defect in the condyle. So what can we do for that? That is what we call 𝗏𝗏𝗏𝗏. Purely a cartilaginous defect. There is no chondral part, means there is no osseous part. The subchondral bone is intact, you have only the cartilage that has been damaged. So in this case, what we can do is, now this place is a non-articular cartilage area of the knee joint. This is outside the patellar articular area. The structure you see on this side corner is a patella, and this is a femoral condyle. This side, this one is a patella, and this is a femoral condyle. This is a medial side, and you see this area. From this area, we are taking a osteochondral graft. We are taking an osteochondral graft, and we are leaving a hole over there. But we are not worried about that hole because it is a non-articular area and less weight-bearing area. And what we are doing is, you saw the defect there. We are cutting out a similar piece of bone from the defect area. This was the earlier defect area, and we have removed the defect along with a small piece of bone. And now the graft that we have harvested from the non-articular surface is being brought here, and we are slowly pushing that graft inside. If you carefully see, if you carefully look, you can see that the graft is going inside. Slowly it is growing. This is the osseous part of the graft, the bony part that is going inside, and the white that is coming behind is the cartilaginous part. So this is just a press fit. You are not using any implant, you are not using any hardware. You just put it inside, you bang with a mallet, and it will be seated there. So this is the final malleting that is being done. So earlier, this area, there was a defect, and now this area, the cartilage is restored. So this procedure is called 𝗏𝗏𝗏𝗏, osteochondral autograft transfer. In countries where they have facility for allograft, they can use allograft also. But in Kerala, we don't have that facility. So they will take the graft from an allograft, means a cadaver, and then use it into the patient. Procedure is for a smaller cartilage defect. If you have a bigger defect, what can you do? You cannot go for 𝗏𝗏𝗏𝗏𝗏, because 𝗏𝗏𝗏 means you have to take the graft from the patient itself. You cannot take n number of grafts from the patient. That will harm the patient itself. So in such cases, what we do is called a autocart procedure. You can see this is a big defect in the medial femoral condyle. See, this one is a big defect. It will up to 6 centimeters. Up to 6, and this is on the lateral side. The same patient is having cartilage defect on the medial side as well as the lateral side. So what we have done an autocart procedure in this patient. After original cartilage of the patient, minced cartilage, we take some parts, and then we take blood from the patient. We make PRP with the blood from the patient and mix that PRP with the minced cartilage, normal cartilage cell, with normal cartilage cells. We mix with PRP, and then for gluing purpose we use some thrombin, and then mixing all the three, we just inject it after debriding the area of the cartilage or osteochondral defect. We debride it, and then we apply this material and paste it and fill the defect that is seen. So this is a wonderful procedure that has come up for cartilage defects. and these larger defects were not amenable to treatment till date. These procedures has become a very good procedure so that the patients can have a normal knee. So all our patients who has been treated with AutoCART, they are having good knee movements. They are very happy. They don't have any pain. They were in severe pain. They cannot even walk. This patient actually is a 45-year-old lady. 45-year-old lady. She was not able to walk because of the pain. And this patient is very happy now. It is 1 year, almost 1 year after the surgery. And she can move around, she can flex the knee, almost in a full range of movements. So this is a wonderful procedure that has come. This procedure, we can do it here. But outside, there is one procedure called ACI, autologous chondrocyte implantation. ACI, we need two procedures. Two procedures means first we harvest the graft, and second we do the second surgery after preparation. So in our setup, people don't buy that surgery because people don't want two surgeries to be done. So AutoCART is an answer for all of that. So if you have what I said is, if you have a cartilage ligament problem, treat the ligament problem. If you have a cartilage problem, treat the cartilage problem. Okay? And don't means I have a knee pain, let's be like that, I will go with that. Don't think of anything like that. If you have a heart problem, if you have a liver problem, you will not leave it like that. Likewise, if you have a knee problem also in a younger age, I am talking about younger people. If you have something, if you have an instability in the knee, if you think that there is a problem, take an MRI and see what is there inside. If it is treatable, you can save your knee. You can save your knee and you can avoid more surgeries. So all these things are 20 to 50 years of age that I was talking. Now think a patient is above 50 years of age. 50 years of age, we don't usually go in for these cartilage procedures. We don't usually go in for these ligament procedures because already the cartilage and the ligament would have degenerated, and there will be thinning of the cartilage, and the ligament functions will be subnormal. So along with that, what the patient will have is, he will either have a varus deformity or a valgus deformity. You should keep in mind, the patient is only 50 years, 50 to 60 years. 50 to 60 years, patient is having a varus deformity, patient is having severe pain. What you can give to the patient? Anyway, most of the people go in for a total knee replacement. We don't advise total knee replacement for such patients. You correct the angulation and make it into a normal anatomical knee. So the alignment is corrected and you can have a normal knee. So I will show you. So this X-ray is called a scanogram. You can, in a scanogram, you can see the hip, the knee joint, and the ankle joint. So what I have drawn is here the mechanical axis of the lower limb. So you can see clearly that from the head of the femur, one line is going up to the ankle, and that line is clearly missing the knee joint. That line is missing the knee joint. This line should have passed through the center of the knee joint. So the mechanical axis is well medial to the line that it should have been. So from this we can understand that all the weight, body weight of the patient is going through the medial side of the joint. So in such patients, if you see take a weight bearing X-ray, you will see that the medial side will be almost bone on bone, but the lateral side will be normal. So we want to capitalize on the lateral side that is normal for the patient. So the medial side, if you take an MRI in this patient, the medial side, the articular cartilage will be 0 mm in some area, will be 1 mm, 2 mm in some areas, but on the lateral side it will be 3 mm, it will be normal. So what we will do is, we will correct, if you look clearly, you can see that the main problem is with the tibia. The tibia is going into varus. The femur is not the problem here. The tibia is going into varus and it is coming close to the other leg. So what we will do is, we will make an osteotomy here and we will make it into valgus. That is what is shown here. And we will put a plate over this and we will make the patient walk in 3 weeks. The patient will walk in 3 weeks. This is such a beautiful surgery that the patient, they can do anything they want to do. And we can promise 15 years for the patient without any other procedures. The patient, why? Because the cartilage on the lateral side is 3 mm thick. It is as normal as a normal patient's cartilage. And now, after doing a high tibial osteotomy, we have shifted the weight from the medial side to the lateral side of the joint. So you have all the years for that lateral cartilage to be worn out. So 10 to 15 years you will easily get. What is the advantage? Advantage is the patient can run, the patient can climb mountains, he can do mountaineering, he can squat, he can sit cross-legged. 55 years of age, if a patient is doing this surgery, up to 70 years, if he is happy or doing all the things in the world, then what more we want to give the patient?
So excellent. Actually, 𝗔𝗀𝗃𝗃, we are really proud of you because നമ്മൾ പലപ്പോഴും എനിക്ക് അതിനകത്ത് ഒരു കാര്യം മാത്രമാണ് ആഡ് ചെയ്യാനുള്ളത്. സാധാരണ മനുഷ്യന്മാരുടെയൊക്കെ ലൈഫ് സ്പാൻ നമ്മൾ വർദ്ധിപ്പിച്ചുകൊണ്ടിരിക്കുമ്പോഴത്തേക്കും നമ്മളെ ലൈഫ് സ്പാൻ മാത്രം അത്രയ്ക്ക് അങ്ങ് വർദ്ധിക്കുന്നില്ല, ചിലപ്പോഴൊക്കെ കുറയുന്നു എന്നൊരു സംശയമാണ്. സോ അതുകൊണ്ട് ആക്ച്വലി ആനുവൽ ജനറൽ ബോഡി വന്നപ്പോൾ എസെൻസ് ഓഫ് മോഡേൺ മെഡിസിൻ ഫോർ എവറി ഡോക്ടർ എന്നാണ് നമ്മൾ തീം ഇട്ടത്. ആക്ച്വലി ശരിയല്ലേ? അപ്പോൾ സോ we must have a big round of applause for Dr. Shamas, and actually we are proud of you, and you go ahead. Hello, വളരെ സന്തോഷം. Okay, President. Thank you.